Hello, my name is Michael and this is my knee examination. Again, Cece's going to help me with this today. Much like the shoulder examination, whenever I do an examination of any joint, I always take a focused history, especially of the pain, the mechanism of the injury, any previous injuries to any joint, and then it would help formulate my differential diagnosis. But today we're just going to do the knee exam. Now before I touch a patient or have a look at their knee, I always ask a few screening questions because we're always told to examine the joint above and below the joint that we want to examine. So the screening questions I ask for the knee would be, have you had any pain in your back, your hips, or your knees or your ankles at all, Cece?
No.
Just to give me a feel of whether or not there could be a referred pain coming from somewhere else. Now, the first thing that I would get Cece to do is stand for me and we'll have a look at her posture and see if there's any gross abnormalities with the way she's standing. So, can you put your feet together for me?
Yep.
Good. So we're looking for any varus or valgus deformity there. And another important thing is to look at the arches of the feet. So yeah, if you turn that out for me, that looks fine. And if you do the other side for me, that looks fine. Sometimes you can look at the soles of the feet and see if there's any calluses formed in particular areas which might suggest an imbalance, but we won't do that today. The next thing I want Cece to do is just walk for me. So if I can get you to just walk up and down just a couple of times for me, and we'll look to see whether there's any problems with the gait. So has she got an antalgic gait? Is she limping? We'll be looking to see whether there's any heel striking, and we'd be looking really just to see if there was symmetrical movements between each leg, or whether she was compensating for pain or injury somewhere. So the next thing I'd like Cece to do, get athletes to do some movements that test them to see if it brings out any underlying problem. So the first thing I'd like you to do, Cece, is if you could do a couple of squats for me. And we're looking to see whether there's any discomfort, especially at the end range of motion there, which might indicate an underlying meniscal tear. And again, looking to see if it's symmetrical on both sides or whether she's compensating for something underlying. But everything looks fine there. Now again, athletes can perform squats even with underlying problems without any sign of pain because of the strength of surrounding muscles. So would ask Cece, could you do some lunges for us, is that alright? And again, with the lunges, sometimes athletes that have ITB problems can localise pain on the outside of their knee. But yeah, there's no obvious abnormality there with Cece. Now, if we were still concerned, we could get athletes to do a one-legged squat, which can show whether they're going into valgus when they're trying to squat and bring out an underlying injury. But we won't do that today. Alright, so the next thing that I'd want to do is have a look at Cece's knees, and the best way to do that is to get onto the examination table. Alright, so make sure the patient's well exposed to have a good look at their knees and above and below. So we're looking for any obvious abnormalities like swelling, erythema, are there any scars from any previous surgeries, is there an obvious leg length discrepancy, which there's not here. And I always like to have a look at the quad bulk, the calf bulk, and sometimes more so for palpation, but we like to look at the Achilles tendons just to see if there's any thickening there, which would suggest pain coming from somewhere else. So everything here seems to be normal. Now we'll go on to palpate the knee. So the first thing I would do is have a feel of the temperature of both sides of the knee. So we're feeling for any hot joints, is there hemarthrosis? Obviously the setting and the history of the injury would be significant if you did have a hemarthrosis. So temperature is absolutely fine. Next thing I'm going to do is feel for, do the patella tap, which pushes fluid from above the knee into it, and it gives you a bouncy patella. But that's negative today. The other thing we can do to see if there's any effusions is a sweep test. So we sweep on one side of the knee and see if we can move fluid from one side to the other. And there is none there. So CC's knee is nice and normal. Now, again, we look at quad bulk. If there was an obvious, if we were worried about an atrophy of the quad on one side, we could measure 20 centimetres from the tibial tuberosity and take a measurement on each leg and see if there is actually a discrepancy. Again, I like to palpate above the knee, see if there's any pain there, palpate the patella tendon, see if there's any patella tendinitis. Tibial tuberosities are important to palpate as well, and we do this on both sides obviously. Palpating the calf and the Achilles as well, just to see if there is any thickening or pain there. Calf squeeze can elicit some Achilles pain as well. The other test as well is a patella apprehension test. So always look at the patient when you're doing this to see if they're in discomfort when you're doing it. If they've had recurrent patella dislocations, then they may do if they associate it with the pain that they had before. Brilliant. The last thing I want to do to have a feel of the legs is to get CC to roll over for me. Yeah. Now we probably should have looked at our popliteal fossa when she was standing, but better to look at it here. So we're looking to see if there's any swelling or mass behind the knee basically. So I'm going to have a wee feel and see if we can feel anything. And sometimes you can get aneurysms in behind the patella there, and they're pulsatile, so there's nothing there. That's brilliant. Alright, so the next important thing to do as well is palpate the joint lines. So the joint lines, medial and lateral, is where you're most likely to have tenderness if there's been a meniscal injury. So I'm palpating along there. CC, did you get any pain there? No, so no pain when we palpate the joint line. Now, we were talking before about assessing the joints above and below. The test that I do to assess the hips that could give pain in the knee is a hip impingement test. So I ask CC to go onto her front again for me. Brilliant. Can I get you to bring your heels up towards you?
Yep.
Brilliant. And we're just going to take those out there and just make sure that both legs are the same and that there's not an obvious impingement, which there isn't. Good, that's fine. Now you turn over for me again. Very good. Now, so we're going to get CC to move her knee. I'm just going to do it on the right one, but we'll obviously be doing it on both sides. So can you bring your heel towards your bottom for me, CC? Good. And then I'm just going to do it as well. And while I'm doing it, I'm feeling for any crepitation in the knee. Brilliant. And any pain at the end range of movement. So full flexion there, about 140 degrees. And I'm going to test for hyperextension as well, where we just bring the leg up and see that it's not hyperextending, and it's not. So that's completely normal. Now, next test we're going to do are the anterior and posterior drawer tests, important for assessing the cruciate ligaments. So what I do is sit on I'm just going to sit on your foot, CC, let me know if I'm hurting you, and we're going to do anterior drawer test and the posterior drawer test, and just feeling that there's a solid endpoint there. And that's brilliant. Next thing we're going to go on to do is assess the collateral ligaments. So in about 30 degrees of flexion, we're just going to pull this out the way there, and again, it's a good endpoint. Now I'm going to come inside you here, alright, just to assess this one. Brilliant. And nice endpoints there, no laxity at all. Now, McMurray's test is a test that I found pretty good for assessing meniscal injury. So what I do is get patients into full flexion. We're going to turn the leg outside, alright, and then I'm just going to straighten your leg as much as you can and all the way back up. And if you feel a click or a pop, that's a positive McMurray sign. It's basically trying to catch the damaged meniscus in between the tibia and the femur. Right, and we're going to turn your leg inside there, and we're going to try and, so we're testing both for the medial and the lateral meniscus there. Brilliant. That's fantastic. So all of the examinations today were normal. If there was anything I was worried about, again we would follow up with some appropriate imaging or a reassessment at another set date. Now, again, if testing the hips or the ankles had given us any problems, we might do some further testing on those as well. But that's how I would run through just an everyday knee examination. And thank you to CC for assisting. Thank you.